Hello, and welcome to the Better Care podcast, where we share the stories and insights of clinicians, healthcare leaders, and innovators who are improving the way clinicians work and deliver care. On today's episode, we have EvidenceCare CEO Bo Bartholomew interviewing Adam Kaufman, a digital health expert and consultant for a variety of healthcare organizations such as Baylor Scott White Health, who he's currently working with. Adam is an accomplished executive, entrepreneur, and board member providing pioneering leadership in digital health, medical services, and healthy living for more than 2 decades. He is known for driving organizational improvements through technical advancements, as well as defining strategic vision. Adam has a PhD in applied microeconomics with a focus in healthcare from the University of Southern California, and also teaches economics as an associate professor at USC. Bo and Adam have a lot of great topics queued up today for healthcare leaders, so thank you for trusting us with your time. Bo, the mic is all yours.
Thanks, Spencer. Adam, we're so glad to have you on our show. We appreciate it. And I know we've got a handful of questions we've talked about, but I've got a few we haven't. So we're going to have some fun. First of all, please convince us that applied microeconomics is a real topic that you can major in, and tell us what that is.
Well, so first, Bo, thank you for having me. It's great to be called an expert, although I may have written that intro, so I'm not sure I'll hold you accountable to it. But from someone I admire so much, respect, and I've had the good privilege to call a friend and a mentor for 15 years, longer maybe now.
I think it's longer than that. We're all
20 years. So I'm trying to make us seem younger than we are.
Yeah.
So microeconomics is the study of kind of individual interactions versus macro, which is big policy and governments and full economies. And applied micro is actually doing it in data. So it's a very real thing, and I'd argue very important. And a lot of the tools that we take for granted in healthcare actually came out of economics. So, healthcare started, most of the studies were big randomized controlled trials. You could do that. And increasingly, we've adopted things like propensity score matching or natural experiments. Those are all techniques that came out of applied microeconomics. So,
all right. I think I'm going to go on record introducing you as the next generation Art Laffer, taking economics and truly applying it to the real world. Which,
he's not sure how predictive the Laffer curve was, but we can go that way if you want.
Well, he got it named after him.
That's how you know you've made it in academia, if you get something named after you. So.
And I'm grateful to call both of you friends, and we're excited to see where this is going to take us. Okay, to kick things off, what are you specifically teaching at USC? Now, is that University of South Carolina or Southern California?
It is Southern California.
Okay.
And I'm a Los Angeles native and live here now. And so I teach what's called econometrics, which is a real subject, but really is just statistics that economists like to name fancier. So I am teaching 300 level statistics class for economics majors.
And what are you doing specifically with Baylor Scott White and several other health systems? I would imagine it applies some of that into kind of the real world, the application part.
Some, although I have yet to fully synthesize my sort of academic interest with the professional. So for Baylor Scott White now, and similar to what I did at the Mayo Clinic, working with them on digital services that they will use somewhat, so applicable to their own clinicians and their own patients, but really with an eye of how do they do this in a way that is world-class, and can extend the kind of great care and patient engagement that they offer beyond where there may be Baylor Scott White infrastructure. So thinking of things that are relatively standard now in terms of kind of digital and virtual care, and thinking about what's the role of the health system in building those and supporting them and partnering, and then how do we scale those?
So for our listeners, we're going to take a little bit of a roller coaster ride on this podcast today. We're going to go back in time, and we're going to go real high level, and then we're going to dive deep down a steep curve to kind of land the plane on where we are in today's healthcare landscape. And Adam and I have known each other for a long time, and we apologize for anybody who doesn't like to geek out on what's happening in the healthcare landscape, because we do. When we first got to know each other, those discussions through a long series of meetings and work together landed me on his board. And Adam, I thought we'd go back real briefly and talk about kind of the landscape, call it 20 years ago.
Yeah.
And what some of the biggest, at least publicly traded or private equity backed companies were back then. And then we'll circle back and how economics did things and to where we go today. So let's go back just a little bit and talk about some of the services that were really dominating the landscape 20 years ago.
Yeah. So as you know, Bo, but for the audience, I sort of started in digital health on the parts of the healthcare world that I've always bridged consumer and healthcare. So a lot of that was in weight management, in physical activity, in sort of the call it medication elements of diabetes. And if we think back 20 years, like really none of that existed. There wasn't even really a great name. It's hard to imagine, but I started doing this before Fitbit existed, before there was an iPhone. We were sort of hacking at SDKs for research quality accelerometers to build visualization of physical activity and programs. And so there was a handful of people, and most of the early stuff was actually done at research universities. I know you've worked with a number. And so some of the early work was building things in partnership with the university to figure out how to take it. So for us at Canary Health, I was doing it with the University of Pittsburgh, building the online version of the diabetes prevention program, and then trying to figure out how you might sell that. This is before the DPP even existed, before there was reimbursement. And so it was not really much of an industry at all. There was not even mHealth or eHealth, which really came 5-10 years later as the iPhone became a real thing. But if we fast forward, the kind of 2012, 2013 is when you start seeing the first set of companies that we'd all know the names of. So Omada and Vongo were sort of founded then. And most of the early work was still in diabetes, but found a way to couple medical devices that people needed with kind of the coaching and kind of telemedicine. I had the good fortune actually of meeting Jason Gorovich right after he became CEO of Teladoc when I was working for a small company in Connecticut. And Teladoc in 2011 was 10 million in revenue and 20 people. And, maybe exaggerating, but it was not a big company by any stretch. And, obviously it has gone on to do stuff. So it was really 15 years ago, sort of the start of all this. And I think what we've seen over the years is how it has become more and more about care and enabled by technology and less about the tech at start. There was this whole thing that I know I was part of with the prescription digital therapeutics and standalone software. And I think there's real need for that, but it has never gotten to the scale that companies that unfortunately have not sort of met their goals in Achille or Click or Pear that went public have been able to hit. But what we've really seen is a huge flowering of kind of virtual remote care coupled to in-person and sort of the digital first. And a lot of those were companies that had started under one model and then figured out if they brought clinicians in and actually delivered care and could bill for it, they could scale and be successful. So there's a lot in that scope. Let me pause and let you pick it apart or dive in anywhere you want in that.
Yeah. Starting pre-iPhone makes you sound very experienced. So Adam, going deep for just a second, 20 years ago, there was a publicly traded company called Healthways. Right around the corner from my office is here in Nashville. A lot of great people who worked there. They were the darling child. And yet, unlike a lot of the companies you have mentioned, they don't exist anymore. And there was a number of, we'll call them, broadly speaking, disease management that attempted to do a lot of the same things, but were not successful. Any thoughts specifically on the difference then versus some of the companies you've mentioned now?
Yeah, I actually had the good fortune of joining the Disease Management Association of America's board when it was transitioning to what became the Care Continuum Alliance and the Population Health Alliance. So first, just from a process standpoint or sort of what was similar is a lot of what, the digital health companies are doing now and a lot of what Healthways and other disease management was thinking about population health, thinking about coaching, thinking about providing interactions between office visits, which is, we all know an office visit for someone with a chronic condition is just not a sufficiently frequent and in-depth enough experience to actually get at a lot of the core behaviors that drive outcomes. So similar idea. From a mechanism standpoint, we just said the iPhone hadn't even come out. You still got charged per text message, if I remember correctly. So, most of this was telephonic. And so from a product standpoint, most of it is shifted to digital first, chat, sometimes asynchronous communication to then synchronous, and often not even on the telephone. So I think there's a modality switch. But what really happened, and, I think there's been some changes in this, but still some of it's the same, is what really hampered the disease management industry, as was when CMS came out and did this big study and showed that it really wasn't cost saving. That I think they drove better outcomes. They reduced costs somewhat, if I remember the studies appropriately, in the patients who got it, but not enough to overcome the cost of the disease management. And so you went from a darling industry that was growing dramatically, that had a number of companies that were either public or going, to really the cratering the whole industry as CMS pulled back from doing it, and then the other payers who were the main clients pulled back as well.
So that tees us up perfectly. We've done a little bit of time travel into the past here. We're going to pull up, get up to the top of the roller coaster here. If you're a healthcare executive at a health system or an insurance company, walk us through today's economics of healthcare. It's a significant 18 to 19% and growing percent of our
$4+ trillion. It's hard to wrap your head around the amount of money.
It really is. And I know you as an economist can appreciate the inflows and outflows of that. First of all, how should we think about the economy specifically related to healthcare?
Yeah.
And or how some of the economic indices impact that. And let's start there so we kind of understand where we are here in September of 2024.
Yeah.
And let's start there.
So 2 really good questions. Let's start with kind of the big kind of health economic data, and then we can take a perspective of an executive, a particular player in the sector. I think the thing that most people find surprising is the vast majority, so roughly 2/3 of all money spent in healthcare goes to providers. And that's roughly evenly split between hospitals. So think of facilities and, the physician practices who either attend at the hospitals or run independently. The health plans are 10 to 15-ish%, closer to 10, interestingly. Government as a actual player is maybe another 10. Pharma, most people demonize, is 10%. It's slightly growing as well. I mean, I'm putting stylized numbers. And then there's what I've left 5-ish% that are everything else from skilled nursing to DME and all the other stuff. And so it is a industry mostly dominated by money flowing to providers. So that's just the first thing to know. And so a lot of people go, well, we got to fix the plans. And to some extent, it's a misnomer because most health plans of any size are actually providers now as well. Like I think Optum employs more physicians than anyone else in the country. But, Obamacare fixed the profit of plans at 10 or 15%, depending on the product type. And so, plans are sort of what they are. And so, it's happening there. Pharma is growing and is meaningful. One of the reasons we blame pharma or hold pharma accountable is there are much fewer firms and they're much, much more profitable than the other firms. There's 10 big pharma companies that make a lot, and there's a $1 billion health system in almost every city. I mean, there's 240 plus health systems that do more than $1 billion in revenue. So that's at the macro level. Last time I checked, and this could be a little old, about 20%-ish of payments are tied to value based, maybe 30%. It depends on the product line. But even there, the vast majority of those are sort of upside only, like bonus, like real, like capitated stuff. It depends on how you count Kaiser and some of it. But so most of it is still fee for service to providers is where I'm going with this.
That's actually the highest percentage I've heard anybody quote.
Okay.
You're ahead of your time.
I'm ahead of my time.
Individual hospitals would typically have 2% to 5% of their population, their patients in a value-based care.
Yeah, I think it depends. The data I know at Baylor is we've got about 800,000 people in our value-based contracting of some type. of, millions of patients we see every year. So
it's coming.
Yeah. Well, it's been coming for a long time. And, it's very subject to politics. It's very subject to individual things. But where I go with that is it's still mostly fee-for-service providers. If you flip it to the provider, most of that is labor costs. Like the vast majority of what providers do is have people doing things, and some are very well paid, but it turns out most healthcare providers, I argue even physicians, given how much school and how much debt they've gone through, are underpaid compared to what they could do in other areas. It's clear that there's a huge amount of inflation. I think, hopefully you'd agree with me, I think there's like 100,000 physician deficit estimated within like 5 years. There's equivalent nursing debt. So labor is still the main issue in care, and it's the main way we deliver, but it's also the main thing that gets paid for. And so you could think about doing labor saving, you think about bringing down costs, but there's a lot that it takes to get done. And I think if you think about why health systems are such bad shape, that's just hard to manage no matter what. It's a tight business no matter what. But the average health system saw declining services during COVID, particularly the profitable elective surgeries. And then they've seen going costs. So there's a small number of health systems, and I've been fortunate to work with two that are doing well. But the vast majority are, sub 5% margin and often go negative and, are understaffed and trying to figure it out. That's the sort of the number one thing in healthcare delivery. And then on the physician side, older physicians are starting to retire. Younger physicians don't want to stay in. Nurses have the same issue. And so, how do we get the supply calibrated to the care? And then the last thing I'd add, and I tend to believe this is true, although, advisory board was sort of the one who said this, there's a future where more and more of the world moves from procedures to therapies. And the procedures that are happening are moving out of the hospital. They're moving to lower cost. These are all good things in general, but it changes the economics of who gets it. Cancer centers do well because the physicians, get to buy the drugs and then they get to administer them. So they keep the drug revenue, but most therapies are prescribed outside and delivered. So there's a lot going on. And so if I were an executive, I'd have a lot to think about. I have more to say, but it looks like I keep interrupting you. So up, down, or to the side, we're taking the plane.
That's a perfect tee up because there's been a lot of headline news. I would say most of the headlines are villainizing private equity getting into healthcare.
Yep.
So tell us a little bit about kind of the reality of private equity being one of those players. Are they reaping all the profits? Do they control all the doctors?
Yeah, I'm not a huge expert, but I it's something I pay attention to. I talked about it. My understanding is, so private equity's been in healthcare 40 years, 50 years, somewhere in the 80s, and mostly concentrated, at least in big dollars, on delivery kinds of things. But I think within 5-10 years, 3 to 4% of all physicians work for private equity. And I think the report we saw says it's 4 to 5% now. It's still a very small fraction of physicians are employed in private equity, a small percentage of the assets. We just ran through where most of the money goes. Private equity depends on what you think General Catalyst counts as and will do with the hospital. But for the most part, it's stayed out of hospitals.
Yeah.
In most states, they can't own the actual physicians or some MSO stuff. So the two biggest parts can't really be managed by private equity. And so we're talking about things like ambulatory surgery centers. They're meaningful in sub-segments, but overall, they're not really driving it. And I think private equity, I won't say this broadly, I'm not an expert in it, but I think in healthcare is probably a good thing because what happens, so let's take, for example, CMS's recent declaration that you can now do stent surgeries outside of the hospital and ambulatory surgery center. I think it's a really good thing. It's a safe thing, brings costs down. It's challenging for a hospital, so other than the hospitals. But the way that then it gets done is private equity responds to that as a profit opportunity. They buy, build, and roll up ambulatory surgery centers and are able to deliver. So they're going to capture something from the hospitals, but it's really them reacting to CMS changing the site of care that's allowed to bill. And that's what CMS wants when they do it because it brings the cost down. So it's hard to vilify.
I love that example. I was just up in Virginia with 3 different health systems for meetings, and 2 of them were beguiling the third because they had already gotten a CON filed for a cardiac surgery center.
Okay. Yeah.
Which is a new entity that quite honestly didn't exist a year ago.
Yeah.
So the innovation keeps coming. Economics are driving those. But I do think it's surprising, and I would think for most out there that don't pay attention, that private equity is about 4% of the healthcare industry, and yet they take up an outsized portion of the headlines, devaluing healthcare, which is not necessarily true. So let's go a little bit deeper now. Let's talk about health systems, since you're working with one, and we work with quite a few all over the country. What are the pros and cons for the health systems creating their own solutions? So we talked a little bit about the solution companies.
Yeah.
And then you've got digital health, and you got company health systems trying to build, buy, partner. Tell us a little bit about how you've advised health systems and how they should think through those things.
Yeah. So if you allow me, I want to add a third concept to that I think is probably more important than whether they buy or build their own, but would drive it. I think when you say these kinds of solutions, whether it's an innovative center of excellence with a digital tool or it's telemedicine, I think, these are the kinds of sort of patient facing. It could be, new algorithms to do care. Like it's these kinds of tools we're talking about. And the question is, should health systems build those? Should they buy them? What I think is more important than either of those, and if we look at the employer space, we can see there's a huge challenge in deploying a bunch of point solutions. And so what I would advise health systems to do is, even before they make the decision they're going to buy someone or build someone, is like, how do you get a unified and integrated delivery of these solutions so they fit more seamlessly into your patient care or your provider back office if you're thinking about models. And so, for example, the work I was fortunate to be part of at Mayo was Mayo not building their own algorithms, but thinking about, for lack of a better word, the plumbing that made it easier for those algorithms to be quality vetted, to be deployed, to be managed, and to live inside of their and other health systems EMR. So they made the choice that they didn't want to own the individual solutions. They wanted to facilitate that, and they're very much part of that. But what they wanted to do is make it so it was easier to deploy them. Because what ends up hurting most of these point solutions commercially is the deployment, the integration. But even when they get there, they get suboptimal usage because you got to go download another app or you got to click on another screen. And so I think that's what is most important. Similar to what we're doing at Baylor Scott White, where we're thinking about, first, what is the front door, if you will? How does a patient find these solutions? How does it seem integrated? And then behind that, some of them we're building ourselves, but a lot of them we're partnering with or taking components and assembling with that. But really important is that experience. You'll remember, but if we go back 20 years, one of the first attempts to do this was a Microsoft product called Health Vault. And we at my startup, Canary Health, were one of the first members. Like, oh my God, this is great. And Microsoft could never get past, and I don't blame them, it was clunky, never get past how do you actually decide you want to install this app and trade data? And that's still 20 years later, a hard problem to solve of like, okay, I'm in something. And in healthcare, there's a bunch of permissions and there's a bunch of other stuff. And so even getting that right. So I think that's most important. And I would say, figure out how you make this experience as good as possible for the provider, the patient, depending on which side you're working on. And then it becomes you can absolutely build it. I would recommend you assemble it. There's good stuff out there. Some of it's worth buying. Sometimes it's your own clinician. Sometimes you can partner with other clinicians. Sometimes it's your own tech. But then really owning the experience in a way that makes sure it works.
And if you're advising a health system leadership on how to successfully partner for different solutions or different ways to integrate, how do you advise them? What advice would you give them?
It's hard. There's a certain expertise. I've been fortunate to be on the other side, scrambling, for lack of a better word, to form partnerships. Most of the partnerships we did at Canary were with pharma and medtech, but other, big companies. And so you got to be careful. Small companies can exaggerate, are selling on their vision. They're not held to the same standards. So one is just, have a legitimate, compliance, regulatory. You don't want to get caught holding something. But I think that's much less of a concern than it was 10 years ago. Most innovative early companies have done that. They get it. There are lawyers and other firms that can validate it. There are certificates to look at. So just be deliberate there. I think doing it in a way that is a group that is connected but does stand alone. I'd love to turn the question back to you, because I'm afraid of like pure innovation groups at health systems or pharma or health plans. My experience has been they get an 18 to 36 month mandate and they disassemble everything. On the other hand, if you try to figure out how am I going to stand up something new and partner from within whatever the actual service line at the hospital, there's a lot of sort of other things that can get in the way, a lot of old practices, a lot of like, I got to get on the Epic team time in competition with something else. So what I saw successfully at Mayo was a real commitment to building a group that lived between it. It seems like what's, we're doing at Baylor Scott White as well, but that's not an easy thing to get right. And you might have more experience having worked with more of like, how do they find that balance between being connected enough to the core processes and systems so they can get on the Epic roadmap if they need it, and IS and compliance, but not so far away and not so far or so tight that they get co-opted, but not so far that they're sort of left to wither when one thing doesn't work.
Yeah, I would say we see kind of three flavors of innovation efforts, for lack of a more descriptive term. I think there are those systems who know they need to innovate or have a desire to, and they create a team and they give them a job description, and for more usually unintended consequences, they're left on an island, and they go to the conferences, they learn a lot, they come back and report, but very little gets done. The second flavor is more of the same, only they are given a pretty large budget, and it's typically called a venture fund, and they get to go invest. In many cases, those, by virtue of just putting capital behind something, they can see some improvement and ramp. But it's by far the third flavor that we have seen the most fruit and outcomes for the health systems, for the patients, for the hospital's bottom line. And that is where it is directly integrated, governed by and or owned by the operators. We've done podcasts in the past with health innovation directors where they admittedly struggled to take very good products, very good tech, very good digital solutions, and they get a great pilot and it's funded by the innovation group, but then gets little to no adoption to scale and operationalize. And part of that is no fault of the organizations. It's just kind of the way things may have been structured at the beginning.
Yeah.
Operators are tasked to deliver on the core business, to take care of patients, and to execute on the financial metrics of the organization. If you don't fall in line with that, you're going to have little to no time given to tend to those digital innovations.
Yeah.
So all that to say, at the very end of it is get operational buy-in, align with the business's end goals, and be a part of those initiatives. Whether you get funded through innovation or introduced through innovation, that's kind of a secondary matter if you're aligned operationally and you can deliver what the health system needs.
Yeah.
Last thing I'll say, and this kind of I'll bring it back to you, is when I was running hospitals 20, 25 years ago, anything involving patient safety or quality could get approved. Today, it's anything that gets approved if it impacts the hospital's bottom line, revenue or...
I think that's right, but I maybe a slight nuance. So I'll take it as a good news. There is enough innovation across all the different functions in a hospital that I don't think a health system should be like, okay, this is the only place to innovate, meaning it's got to be in surgery, it's got to be in patient care, it's got to be in care management, it's got to be in algorithms, it's got to be in pathology, right? There's enough, and because it's a mature enough space. And when I think it's the most successful, and I think this is what you're linking to, but just to be explicit, is when the place that the health system is innovating ties to the broader strategy. So it's not just the bottom line anywhere, it's the broader strategy for the bottom line. And what I mean by that is it's very easy to do a value-based care pilot. But if your health system is not strategically trying to increase value-based care, that's something that's not going to go anywhere. And it's very easy to do a pilot of something that is a new cash pay service. But if you're trying to become more value-based care, that's not going to make, and I do still see a mismatch. Historically, it had been like, what's the, the new shiny object, because there wasn't enough. And so people would gravitate, and it didn't necessarily fit the strategy of the hospital. And you've spent a lot more time in hospitals than I have, but as I've spent the last couple of years and had the good fortune to work at, I think 2 of the premier systems, they have very different strategies. And they're both wildly successful. So it's not like there's only one strategy that wins. And so aligning your innovation to, as you said, the bottom line, but it could also be the top line, but specifically where, like, what's the board slide that is 2 levels above why you're doing this? And if you can't take a board slide that says, here's our 4 strategy, and within 2 steps get to why you're doing this pilot, it's not going to scale.
Yeah. And that was way better articulated, Professor. Thank you. I do think it's the marriage of, quite frankly, for the last 3 or 4 years, hospitals' margins have been the lowest they've ever been and the most challenging. So the number one initiatives become increase revenue, lower costs, decrease length of stay, et cetera. But the real win in the trifecta is when patient care improves.
Correct.
And at the end of the day, the beauty of being an innovator, operator, investor in healthcare is we all have a common purpose around patient safety, increased care, and hence our better care moniker on the podcast. But Adam, as we kind of dip back up and come in to land this roller coaster on this podcast, what are some of the things you're seeing from an innovation and from kind of the economic angle that is driving better care in the last year or so of your work?
So it's still early, but I am more optimistic than I've been in, call it 10 or 15 years, that we're able to coordinate clinical interactions, whether those are remote, virtual, or in person, with the digital journey. Historically, it has been go see the doctor and then you get your digital experience. Go see the nurse, you get, and I think we're starting to platform healthcare where the physician or the nurse or the physical therapist or the clinician who's seeing you has something from your at-home digital experience, whether that's your data, your goals, and what happens when you interact with the clinician feeds back to that experience. And I think that, to some extent, is what we've been collectively working on for decades. And when it started, it was sort of like, okay, the physician will refer to this thing, but it really lives outside of any interaction. And at best, it makes them better. I think the architecture, to some extent, of Epic itself and care plans and other things, to some extent, the prevalence of CRM and chatbots from a consumer customer standpoint, but moving into care, have made it possible to tie those journeys together. And we're not quite there yet, but I'm optimistic that that is the foundation that then lets AI in a care manner get better, automation get better, wearables. Because what we've had before is we didn't know when you needed to see the doctor. We just sort of guessed and you just showed up. And so we're still a ways, but that's, I think, the biggest. And then I do think, having worked in diabetes and obesity for so long, we even talk about my time at Weight Watchers. And I know it's coming in neurology. It's clearly here in cancer. I tend to agree with what I said earlier about advisory. I mean, I think there's a future of therapies that are going to transform disease states and treatment in a way that we just never saw. And I think the GLP-1s are just the surface of it, but that's a huge category that went from either no care or surgery only, or us just all collectively like eat better, move more, and having very modest impact, to potentially making a huge dent on global obesity. And so I think they're coming in neurology, they're coming. So like, it's just I think that those 2 things, the therapy and of one kind of stuff, and then what we're seeing in terms of like platforming healthcare in terms of a hybrid experience.
GLPs is absolutely, I think people don't necessarily appreciate how transformative it is to healthcare. I think everybody knows how transformative it is to their neighborhood and to their neighbors, but it really is transforming healthcare. 25 years ago, one of my initial jobs was to purchase the overweight gurneys and to try to figure out how many we could purchase fit and that would navigate our hallways. And these were gurneys that held over 500-pound people. So now, like those are going to go the dark, which will be great. And so, Professor Kaufman, what is your favorite song? And then what does it tell us about you?
So, oh man, I hope I remember the name. I think it's Happy by is that Pharrell or Will?
That's Pharrell.
And I'm this is going to show that what a good parent I am or what a bad parent.
Okay.
My kids are both in an a cappella group. And I'm pretty sure the last performance they had, my daughter had the chorus of that song as her solo. So it's just a fun song to begin with, but hearing her sing "Clap Along If You Feel,"
well, I think it shows us
that makes me happy,
and it should. You're a man who has his priorities right and who cares. So, to our audience, I want to say thank you for joining us on the Better Care podcast, and thank you, Professor Adam Kaufman, a father, husband, professor, healthcare applied macroeconomist. We're so grateful for your time today, and thank you for sharing your insights.
Thank you, Bo. I really mean this. A good portion of what I know and what I've been able to do has come from your friendship and mentorship. So appreciate being on, and hopefully it won't be another 20 years before we do it again.
Absolutely. We'll make sure of that. As we kind of conclude our time together on this podcast, what are some nuggets or things that have kind of caught your attention in the last 10 days or so?
School starting, the kids' soccer starting.
The world is coming back in order. We've got school started, football's on TV.
There's the election is kind of ever present, right? There's
any predictions that we can have pre-recorded on the election that we will release after the election that you'd like to give?
I mean, I think it's safe to say that if Trump wins and follows the policies of his first term, we'll see a slower move towards value-based care. Biden put some of Obamacare back, but didn't really make it a huge centerpiece. I think some of that, I don't know if he wasn't as passionate about it, the administration, or there's other priorities. I'd be willing to bet Kamala Harris thinking about 2 terms, coming back to healthcare. You would see a very different future for the pace of value-based care and how aggressively CMS moves with a Democratic administration versus a Republican one. I don't know if that counts as a prediction since I gave both sides.
We'll edit and cut out the one that wins, so you get credit.
Perfect.
All right. What is your favorite song?